Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. This is a series all about the unique medicine and working life that comes with operating in Alice Springs and the greater Barkly region. You're currently listening to our Renal series with Dr Anosh, who's a dual cardiology and gen med advanced trainee at Alice Springs Hospital. My name is Indi and we're currently on our third episode of our Renal series, and today we'll be talking about missed dialysis, having recently spoken about haemodialysis. Thank you, Anosh. Thanks for coming on the show again.
No worries. Thanks, Indi.
Firstly, I would like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country, and that we work on their stolen lands. To recap, haemodialysis replaces the kidney's function of fluid and waste removal, namely potassium, creatinine, urea, and hydrogen ions. Haemodialysis is the most common form of renal replacement therapy in Central Australia, with hundreds of patients currently on dialysis. It occurs 3 times a week, often for 2 to 4 hours, and it's an extremely time-consuming and physically demanding medical intervention. So for a variety of reasons, sometimes dialysis is missed. Today, we'll be talking about the signs, symptoms, investigations, and management of patients who have missed dialysis, and this is a clinical presentation that you'll commonly encounter in the emergency department of Alice Springs Hospital. Anosh, can you expand on some of the reasons why we see it so much?
When I started this year, I was studying renal medicine, and it was obviously an experience like no other, especially compared to my time in Sydney. And the reason for this, I think, was the missed dialysis patients that I was seeing. There's obviously a lot of reasons as to why people miss dialysis, and I have to say that a lot of that comes down, unfortunately, down to sorry business, going out bush a few days, but also a lot of the time it's actually a harbinger of them being unwell. In terms of the burden, I would probably see at least 2 to 3 patients a day on average who have missed dialysis. And it puts stress not only on them in terms of their bodies and their ability to cope with the symptoms they present with, which I'll talk about shortly, but also on our hospital system with regards to the impact on our nursing staff who are working tirelessly on the bed situation in terms of our limited dialysis chairs in hospital. But then also we have to think about our satellite units, namely Flynn Drive, as well as Gap Road dialysis centres, where they easily can't take patients back because they're already having not enough chairs for the amount of patients that we have with the increasing burden of people starting and commencing dialysis. So it is, I think, multifactorial as to why we see so much of it. But I think in addition to what we do acutely, there are a lot of wonderful people in our multidisciplinary team, both medical and non-medical, trying to work on looking into how we can be better with primary prevention, looking at the social determinants of health. And I think with every missed dialysis, it's important to not only stabilize them, but then really think hard and have a very friendly, non-confrontational, non-judgmental and non-biased chat with that patient and their family about what can we do to try and minimize this from happening, give them very good, culturally safe education about the importance of missing dialysis and how that's going to be a burden on them and potentially limit their longevity and life, and then try and see if we can assist in regards to any social issues, but also in regards to geographical factors.
Okay, so if a patient just misses one dialysis session, can they turn up to their next dialysis appointment without issue, or do they have to come to the emergency department and be stabilised?
It's a tricky question, Indy, because I think every patient is different. And one person's, for example, potassium of 5.5 may be completely asymptomatic, whereas someone else may actually have symptoms with a potassium of 5.5 just because their body is exquisitely sensitive to that. For example, having a junctional bradycardia or hypotension or a ventricular arrhythmia. So it's important to be aware of these patients, and I think we've got a good system here in Alice Springs where in the outpatient setting we get calls from our dialysis nurses at Flynn Drive and Gap Road dialysis about anyone who misses dialysis, but also reaching out to our Purple House dialysis centres, for example, and Bladderwatch, Kintore, and they basically talk to us about these patients. And essentially what I would want to know is what are their hemodynamics? So what's their blood pressure, their heart rate, how do they look from the end of the bed? Secondly, I want to know, again, what the reason is if we have one for why they missed dialysis and whether there's a chance it could be happening anytime soon that particular week. And then thirdly, if they've got some biochemistry, I would like to know what their potassium is, what their urea is, as well as their sodium. Like we talked about earlier on in the chronic kidney disease podcast, these markers are very important to try and triage what's going on. So if they've just missed one dialysis, in general, from my experience in 6 months of Alice Springs Renal, is that we probably would be okay most of the time for them to actually attend their next dialysis appointment. But we may just temporize things by giving them, for example, some salbutamol initially, seeing what the response is, because the potassium will go down, or giving them some resonium, again, for a similar effect of trying to get the potassium salts down. And thirdly, if they're passing urine, we may consider giving them furosemide. So it just depends on sort of all those factors in terms of us making a decision. But if we're not sure, it's always better to be safe and cautious, keep them admitted in hospital, and then try and work out the best thing by prioritising the patients that we have.
Mm-hmm. So I'm a junior doctor working in the emergency department, and someone has brought themselves in with missed dialysis because they're feeling really unwell. What are the signs and symptoms of missed dialysis commonly?
Yeah, that's right. It can range from just being completely asymptomatic to just being quite floridly symptomatic. But just to name a few from my experience working here, they can range from shortness of breath, either at rest or on exertion, orthopnea, to having neurological issues and symptoms such as having a nasty headache, blurring of the vision, or just generally feeling yucky and queasy with nausea, vomiting, diarrhea, and then even presenting with a chest pain or an abdominal pain presentation. And then on examination, you'll find that these people can be quite tachypnic with an oxygen requirement. They can have features of failure, which may be sometimes hard to distinguish from cardiac failure, especially if they've got multi-organ failure, such as elevated jugular venous pressure, bibasal, inspiratory coarse crepitations, as well as peripheral edema, not just in the legs, but also in the sacrum and ascites. And then some people can present in this florid state of fluid overload called anasarca, where they have fluid up to their neck, and it's really important to try and relieve that with either Lasix plus or minus dialysis. But you have to always compound the symptoms with their vital signs, namely their blood pressure. A lot of the times you'll find that as a result of the fluid on board, the blood pressures are going to be high. And a lot of the time treating the blood pressure, the key is really dialysis, and that's what's going to help. We obviously give additive agents, as you've seen, including atenolol, irbesartan, ramipril, prazosin, hydralazine, just to name a few of the other agents. But the key is getting fluid off and doing it in a careful manner, and that's with dialysis. In terms of the other manifestations I talked about, you've got to think about hyperkalaemia as part of that initial acute indication for dialysis. So the quickest and most accurate way to work out if someone's got true hyperkalaemia or erroneous hyperkalaemia is actually a 12-lead ECG, because obviously you can get hemolysis samples on a VBG or venous blood gas or a full blood count and electrolytes, urea, creatinine for that matter. And the ECG changes can obviously vary from the classic textbook findings of peak T waves with tenting in the anterior precordial leads to PR, interval prolongation, QRS, interval prolongation. And then when you, for example, get into the ranges of more than a potassium of 8, you may get a sinusoidal pattern, which is always a disaster. And in those cases, the quickest and most efficacious thing to do is to give some salbutamol because it's very fast acting and it also doesn't require intravenous access.
Just a quick question. I used to see that the degree of hyperkalemia would correspond to certain ECG changes, starting with PR prolongation and then going to those other ones you talked about. But I've also heard that that's not true.
Yeah, it's a good question. A lot of patients may not have your textbook sort of findings for potassium, for example, of 7.5. It's always important to compare it with previous ECGs and see if that's new for that patient. But if they've also got corresponding cardiac symptoms like chest pain, dizziness, palpitations, in addition to ECG changes, then it is probably worrying. Now, it's a good point you raised there, Indi, because one of the other things we normally do in a ward level in a non-renal patient is thinking about calcium gluconate early on for membrane stabilization. Now, whilst that's something that we do tend to do, if someone does obviously have ECG changes, we have to be very careful because we have a significant burden of people coming with missed dialysis, and usually the same patients sometimes over the space of 3 or 4 times in a fortnight. And if we give each of these patients every time they come calcium gluconate or calcium chloride, what's going to happen, unfortunately, is that we're going to increase that dystrophic vascular calcification, which is going to overall increase their long-term cardiovascular morbidity and mortality risk. So unless they've got extremely worrying ECG changes with tented peak T waves, that is definitely new compared to old ECGs, significantly prolonged QRS, and hopefully not having a sinusoidal pattern, I tend to give calcium gluconate. But if we don't have any of those ECG changes, even with a potassium of 7.5 or 7, I tend to try and bring it down with other measures such as salbutamol, rosonium or frusemide if they've got some urine output, and then obviously repeat the venous blood gas, see where we go, and then work out whether we need to dialyse them that night or the day after.
And that would mean calling in the on-call renal nurses. And from my experience in emergency, have seen us hold on to people till the morning who are stable enough to be dialysed during working hours. I'll just mention as an aside here that when the potassium is above 7, we usually at ICU know, or dialysis up in the ICU, as opposed to in KDU, which is our inpatient dialysis unit in the hospital. Anosh, what is the role of insulin dextrose infusions for hyperkalaemia management here in Alice Springs?
So the reason we don't tend to give insulin, especially in patients here, is for 2 reasons. Number one, talking to Dr. Paul Halliwell, one of our ED directors here in Alice Springs Hospital, there were very nasty incidents early on of giving insulin causing severe hypoglycemia and precipitating comas in some patients, especially when we gave it in addition to dextrose. And the second thing is a lot of our patients are very young and we need to try and preserve vascular access, because vascular access is going to be important in the longer run in regards to creating a fistula, which we have obviously talked about in our last session. The insulin and dextrose obviously is a modality that can be used for hyperkalaemia because insulin basically stimulates the sodium-potassium ATPase on the cell membrane. So you have 2 potassium cells going in and 3 sodiums coming out. But those are the reasons we don't tend to use it. And therefore we use salbutamol instead, which obviously doesn't need intravenous access, is easy to use. And it again stimulates the sodium-potassium ATPase. The only thing with salbutamol we just have to be careful about is someone who has already got a history of atrial fibrillation or atrial flutter or ischemic heart disease. We do need to be careful about the amount of salbutamol we give because it is a tachyarrhythmic, and as a result, there's a chance that it can increase beta-adrenergic activity and lead to VT and VF, but again, in very rare cases.
We typically give 10 milligrams of nebulized salbutamol, but I have heard that there might be some harm in doing this prior to imminent dialysis due to moving potassium into the cells and reducing that potassium concentration gradient that dialysis relies on. What are the thoughts on this?
That's an important question, but I think it depends on every patient and individual scenario. Usually, potassium is important for cardiac excitation as well as rest, and it is a degree of hyperkalaemia and its manifestations both clinically in terms of cardiac symptomatology, such as chest pain, palpitations, lightheadedness, dizziness, but also in terms of imaging findings, especially in regards to the ECG, demonstrating features, as we talked about, with regards to hyperkalemia that dictate what we need to do and how quickly we need to do it. Yes, dialysis obviously operates on the electrochemical gradient of moving potassium into the cells and as a result lowering the potassium. But at the same time, if someone does have, again, cardiac symptoms or concerning ECG findings, it is important to act upon that quickly with not only salbutamol, which will obviously move the potassium into the cell, but also think about calcium gluconate for membrane stabilization. And then in regards to dialysis, you can actually adjust the potassium bath just before we start dialysing, so that should not be too much of an issue before we go ahead, but it's something that we do need to be vigilant about, and it's something that I would expect the junior doctors to please speak to the registrars about because it's a very complicated process.
Yeah. We've just spoken about hyperkalemia and misdialysis. What is the significance of elevated urea in misdialysis?
Yeah, that's a good question. So as I talked about before, uremia is that clinical syndrome, and it obviously can range from just generalized fatigue to someone who's actually significantly encephalopathic, if everyone's got chest pain. So it's important to do an examination and assess these patients and then work out obviously if they need dialysis or not, because that in itself is an indication. But the hyperuremia is also important, and the level we normally look at is a urea level of greater than 40. And the reason is when the urea level gets to above 40, we do need to give them dialysis. We do need to keep them in hospital, but we do need to do what we call gentle dialysis, and we tend to give this agent or medication called mannitol. And that's to prevent or minimize the risk of what we call DDS or dialysis disequilibrium syndrome. And just very quickly, for your understanding, urea is, again, like sodium, a very osmotically active agent. And as a result, if you take out fluid very quickly and therefore dialyze a patient with a urea above 40, especially after, say, missing 2 to 3 sessions, you're going to be changing the osmotic gradient very, very quickly, such that the fluid in the cerebral cells start to swell up, and then you can actually result in causing confusion, headache, dizziness, and in some cases coma. So to minimize that and to reduce that gradient, we give people mannitol, which is acting as an osmotic diuretic, and that will help sort of balance things out. So above 40 is the level that we use.
So to summarise the episode, we've talked today about the important emergency management of missed dialysis. When you pick up a patient in ED, there's lots of things you need to know, but it can be simplified to a few things. How fluid overloaded the patient is, including examination findings and weight above dry weight, potassium level, as well as sodium level, urea level, any ECG changes, and also the reason for missing dialysis. We call the renal registrar and they make a decision about timing and coordination of dialysis, and also for any further emergency medication management of the above mentioned imbalances. Thank you, Anosh, so much for coming on to the episode, our third episode in our renal series to talk about missed dialysis. It was great having you on for these renal series, and I really appreciate all of your intellect.
No worries at Indi. I'm hoping it's going to help and make the transition from medical student life to internship a lot easier.
It definitely will. Thanks again.
Thank you.
Desert Docs, a junior doctor's guide to Central Australia, is an NT Health Media podcast produced with the help of ACCC Studio.